the wild world of the diagnostic lab space, nothing is off limits. With science, compliance, sales, and marketing. Welcome to Lab Results with your host, Blake Ford. Hello, everyone. Today, I am with William Baus. William is a resident expert in the MolDX MAC. If you are watching this podcast, today's April 15th. If you're just starting it, what's going on is MolDX is official on April 17th. This is causing a lot of consternation and complication for laboratories across the country. It's going to impact lab owners, their billing teams, their sales teams, and we're bringing in an expert to be able to help explain it to us so that way we know how we can best develop a plan from here. First, we're going to figure out where is here. William, welcome to Lab Results with Blake.
Thank you. William Baus, living in basically Dallas, Texas, working with laboratory revenue cycle management since 2010, inside labs, outside labs in billing companies, helped billing companies put together laboratory specific billing services, helped laboratories incorporate external billing entities along with in-house resources to get their billing done, advising always from the perspective of the lab, what is in the best interest of the lab. And that's my
so in other terms, been there, done that, got the t-shirt.
That's right. So
if you started in 2010, then you've been through some stuff. You've been through the anatomical pathology contractions, the toxicology contractions, the NGS contractions, and now we have MolDX.
Right. Oh, and don't forget CGX, right?
Oh, that's true. Yeah, I forgot about that. I have them like scars and tattoos across my soul. Right?
Up, down, right?
I say it's like if you have a year of lab experience, it's like dog years. So if you've been in it since 2010, we got 12 years, you're 96 years old.
I love it.
Well, if you can give us some gravity as far as, what is MolDX and what is a MAC and where is its impact at right now?
Okay, shall I go ahead and do the geography?
Sure.
Yeah, let me put that out there. That should be, is it coming up? I can't see the little line around.
I can see you.
Okay.
Perfect.
All right, good. So, MolDX is the molecular diagnostics program that a MAC, which is a Medicare administrative contractor, which is technically a private company that's been awarded geographic jurisdiction to process claims on behalf of Medicare. So some of you might be familiar with the concept of a TPA, a third-party administrator. That's what they are. They're private companies that make a lot of money doing this for Medicare. And so what you're looking at on the map here are the different jurisdictions, or what we would call MACs, right? So you can see, you've got Noridian, JE, and then you got Noridian, JF. That's the Noridian MAC right there. Novitas, as you can see, is Texas and the contiguous states, plus Colorado and Alabama, right? And then you've got, or excuse me, that's Mississippi. Then you've got, well, this says Cahaba, but it's now Palmetto, right? So what this is here with Georgia and everybody, this is all Palmetto, the dark pink and the
that confused me this week. I was looking at it and I was thinking that Georgia was Palmetto, and I was referencing a map just like this. Thank you for bringing that up.
Yeah, I just pulled this up and I didn't pay attention that this must be one of these older images of it, right? And then of course you got First Coast, which is basically just Florida and Virgin Islands and Puerto Rico, I think. And what's interesting to note about First Coast is First Coast and Novitas are basically the same parent company owns both of them. And then of course you've got CGS, which is Tennessee and Kentucky and Ohio. And then you've got WPS, which is in two places, right? You get in the middle of the country over here and then right up through the Great Lakes. And then you've got NGS. Now, the MACs that subscribe to the molecular diagnostics program, the MolDX program, I refer to as the MolDX Max, and there are 4 of them. So it is Noridian, it is WPS, it is Palmetto, it is CGS, and did I say WPS? There's another part of WPS
Yes.
over here, right? So it's those 4 Macs. They utilize or subscribe to the MolDX program, which is owned by Palmetto. You know, obviously no conflict of interest there, right? Now, the other thing Palmetto owns is the DEX Exchange, and the DEX Exchange is the database where you record your Z codes, right? And so if you're a MolDX Mac, that means you access the DEX Exchange database to look for somebody's Z codes. But before we get into all of that, what has happened is there is a new LCD, and as you can see here, it's called the Molecular Syndromic Panels for Infectious Disease Pathogen Identification Testing. And we've just had this LCD drop. It will be effective as of 4/17 for services performed on or after. And so your service date is the date you collected the sample. So you technically might be billing things past 4/17 that this LCD won't have any impact on. But as soon as you're billing for something that has a date of service on or before 4/17, then the rules in this LCD billing and coding article will apply. And so let me go back there. So then, you know, the first thing to kind of pay attention to is, do these changes have an impact on my lab? Well, it has a very direct impact on your lab if you're in any of those Noridian states, any of the WPS states, any of the CGS states, and any of the Palmetto states. And remember, this Cahaba thing is actually now Palmetto. So if you're in any of those states, you now will be bound if you are doing, you know, RPP, UTI, STI, GI, meningoencephalitis, blood, infectious disease panels. I think it's also important to note too that these LCDs are referencing nucleic acid amplification tests. That being, you know, PCR is one of the types of methodologies. LAMP is another one. There are many others. So that also means then it is not covering, for example, NGS testing, which, by the way, there aren't really any codes for you to use for infectious disease. So probably not a great idea to go, okay, let's figure out how to do it on NGS testing just yet. But, you know, it's not fish. It's not related to fish. I think there's also a mass spectrometry type of way of looking for infectious disease pathogens as well. And so it's not covering that. So it is related to what most of everybody is probably doing, is PCR testing for infectious pathogens.
So
let me say
it again for your sales rep. So, you know, if you are calling on gastrointestinal doctors and you are telling them, hey, your patients have, they're coming in with diarrhea, and you can now identify the pathogens very rapidly, no different than we can with COVID. And you can find out if your patient has a virus, a bacteria, or a fungus, whether you're calling on the call points of dermatology, urology, urgent care, family practice, long-term care, gastro, wound. You are being impacted now because respiratory and GI are specifically called out. And I'll let you get more into the details of that, William, but I just wanted to bring this back home to it doesn't matter your call point. And it also doesn't necessarily matter the panel of the test, because these changes, when you start talking about Z codes, really impact all laboratory developed testing in molecular diagnostics, focusing on that DNA amplification.
That's right. That's absolutely 100% right. And well, so as you can probably guess, this doesn't mean yay, more money. It means not that. I think the core meat of this LCD to understand about what the impact is to a lab that wants to do infectious disease testing in those states that we just got done talking about, is, well, number one, you either need to be FDA approved, or you need to be able to get a Z code. So, and where does it say that? Well, it says that right here in the LCD, and I'm actually running it through the LCD instead of trying to make a pretty presentation out of it, so that nobody gets lost into thinking that maybe there was a misinterpretation or you didn't get all of the information.
No, it's like I've been shooting people. I'm sending them links to the LCD, and it's like, read it. It's like this isn't fake news. This isn't something that we're trying to scare you into. This is a wake up call for you to realize that if you haven't done the work needs to be done, period.
Exactly.
Yeah.
And as you can see here, it's clearly saying services that do not have FDA cleared and approved uses, as well as actually using that FDA approved and cleared test in ways consistent with the intended use instructions in the labels, right? I mean, we're talking about shipping, even handling and stuff. I mean, I'm not even getting into, that you had the right machine and you used the reagents and you didn't cut it or anything like that. So all that goes along with that, right?
So in this business, basic laboratory medicine, and the audience should be able to track with this, especially if they're a lab executive or if they are sales rep. That's pretty much people I'm talking to, because the scientists already know this, but you've got an insert and there's a description for that quant 12. And I'm gonna go out on a limb this because I own a couple of them, but I'm pretty sure it says for research purposes only, not for patient testing. And that means it's not FDA approved.
That's right.
That means we do laboratory developed testing, and there's an LDT process that CLIA and CMS has fought the FDA over. Who's going to control lab tests, right?
Yes.
Where's this go? Does this give more power to the FDA?
Well, I think what it is it's a really good way that any payer could do this, by the way. It's also interesting. Although commercially speaking, as far as PCR testing goes, most of them considered experimental investigational in the context of UTI, which I've been doing the most research on. But in general, they're saying PCR testing is experimental investigational, which is interesting because what do you think they're paying for COVID with right now, right? I mean, but it's just a way for them to not pay. And it's a death sentence, at least as it is right now, commercially speaking, because, well, they don't want to pay $400 or more for doing a UTI test or PCR when they can just as easily pay $50 or less for doing a culture, right? Mm-hmm. And that's really what you're dealing with here, is an argument about how much does all this stuff cost, right? And is there a way I can prevent or stave off paying for it until the technology drives it down, right? I mean, toxicology came out $2,000 without even worrying about patient responsibility. That was happening on the average for every cup, right? But now you can do a tox test for $20 or less, right? So they're going to push it as far as they can to not pay it until such a time as we get our technology down to being able to get those costs down. And I mean, I had an interesting conversation. I know I'm getting a little off topic here, but tell me if I go too far off the rails.
Sure.
But I just had a conversation with people yesterday, and they thought through the combination of a couple of different vendors, which I'm not promoting, so I'm not even going to mention them, but basically $1 per pathogen, $3 plates, right? So if you're going to do a 30 pathogen panel, you could probably get it done for $30, right? So when I end up talking to you about codes and reimbursement, I think you'll see, hey, maybe there's still meat on the bone if we figure out how to get it down that far, right? And I've heard other people using an FDA panel, like I'm not going to mention it, starts with a B. It apparently is costing them $120 to do their panel. And I mean, that's a death sentence for these guys, because they're going to be limited to an RPP panel of 5 pathogens or less. The reimbursement on that's $142.63. And they already paid $120 on the consumables, right? So there's no profit margin there. Mm-hmm. So I think you are going to need to do your LDT. And it isn't necessary to get the FDA approval because, well, if you don't have FDA approval, you are required to register with the MolDX program and get a technical assessment. So you're talking about a Z code and a technical assessment. And I'll get into what those things are, but you're talking 45 days and 45 days probably smushed together to get that done is at least on the website for MolDX, the Dex Exchange, I think it was, it's 45 days for them to approve it. So assuming you've done all the work to get your 36 steps done for getting a Z code, which are things like what gene and what loci and what variation, what mutation. And then there's a section on 510K, which if you don't have it, you don't have it. And then there's, other sections. A lot of the stuff you would have gone through in the validation of your LDT, but some people don't do all of the stuff for their LDT. Like, did you actually put it in a truck and measure the temperature and do the time? Did you do that? That stuff comes up in a Z code, right? So if you've never done it, you're going to have to now do it, right, to get it straight. But my biggest key takeaway that I meant by showing us this big nasty document was they say really clearly, either be FDA or get a Z code. Now, true to form, let's make it clear as mud, Medicare. Let me show you what they do next. Now, this is the article that your billing and coding guys are going to look at, right? Or ladies. This is what a biller will refer to make sure that they can instruct the lab properly on, hey, you do have diagnostic code requirements. Not in all instances are the tests that are paid for by Medicare or other payers, do they actually say you must have a certain diagnostic code. But when and where they do, that does mean if you don't have this diagnostic code down on the claim form, they are not going to pay for it, okay? So we go through the article and and here we go. The way these articles work, okay, is they group CPT codes together, such as group 1, and this one is for the RPP panel of 5 pathogens or less, which they call the targeted respiratory pathogen panel. Well, when I have a group 1 set of CPT codes and they say, oh, I need to use an accompanying ICD-10 code, they're talking about group 1 ICD-10 code. And I'll scroll down and show you that in a minute, just so we kind of understand how this document works. But what you can see here very clearly is they say, these codes do not require a Z code when billed with an appropriate accompanying ICD-10 code. And I think what people are forgetting is that the LCD said, well, you need to be FDA approved or have a Z code. And so what this is saying is that these codes are covered under limited circumstances, meaning that you've got an FDA approved test that you're using, right? And so if you forget that part and you just read this part, then you think, oh, hey, no problem, I'm good to go. I'm going to use one of these CPT codes and I'll make sure I use one of the accompanying ICD-10 codes. Now, in respect to a respiratory pathogen panel, they looked at it in 2 ways, right? Way number 1 was 5 pathogens or less. And guess what? The diagnostic codes you've got are easier diagnostic codes. They're things like cough of different kinds, right? Fever, even a COVID is in there, right? And you only need basically a symptomatic diagnostic code. Once you move into 6 or more pathogens, now we're talking about a much, well, you're talking about immunocompetent patients, immunocompromised patients, COPD, transplant, HIV, a bunch of different genetic syndromes that have an impact on your immune system. Oh, and yeah, let's also throw in, you need a pulmonologist to order it now, or an infectious disease specialist, of which there are like a handful of them in the entire United States. There aren't many of them, right? So, that kind of really precludes the typical pattern you would see for an independent laboratory kind of having access to those types of patients. You're going to see those people in hospitals, right?
Yeah, William. So let's say, because today's the 15th. This thing goes into effect on Easter Sunday on the 17th. On the 18th, we're going to wake up. I got a laboratory that is effectively going to run a test. They've got a HIC for 1,500 based on the requisition form that the physician filled out.
Right.
They ordered a panel. They ordered a panel of 28 respiratory pathogens because it's a pediatric patient, and they're would they be considered immunocompromised if they're a pediatric patient, or do we have to have some type of a cancer diagnosis?
It'll be a specific diagnosis, and I can let you see just some of the words, sarcomas and things like this, right? Yeah.
The root of this question is, can I run? I'm asking questions because I don't know. doesn't mean I'm trying to encourage anybody to do anything that's wrong. All right. So can I run a panel that's 27 pathogens, because that's what the doctor ordered, and then turn around and only bill for 5 pathogens because that's what the LCD calls for?
Oh, well, that's interesting you bring that up, because they actually thought that, right? Or thought of that, right? And so in the LCD, I forget exactly where, I could probably search for it, but I'll just, in the sake of time, I'll just try to quote it for you. It basically says, hey, look, we understand that, you know, there are technological limitations related to the instrumentation for laboratories where you're going to need to run a bigger panel every time. And you know what? We're cool with that. We are totally fine with that, but we're still only going to pay you for what's medically necessary.
Okay.
So yeah, we kind of got out of that problem of inducement, and that, you know, I mean, I think you could still be brought up on, you know, saying it was inducement if you go out and tell everybody, hey,
25,
I'm going to give
5. No, yeah, that's really where my mind went, because I'm trained to believe that I can only bill for what I test for. But if I am a CEO of a laboratory right now, and I'm hearing this for the first time, which I talked to 23 now, lab CEOs or sales reps that did not know, out of 25, that did not know that this thing existed, which is crazy that this flew under the radar and crept up on the market like it has.
shameless self-plug. You need to hire me to do your policy navigator for you. It's $500 a month, 5 panels and 5 payers, right? And I'll keep you aware of what's going on.
Yeah. So the plug be known. But I'm sitting here and I'm thinking, man, I don't have time to rebuild my requisition form. I don't have time to rebuild my laboratory compendium in my LIMS system. I don't have time to redo my marketing material, retrain my sales reps, because I've got 300 samples that are coming to me for patient care. So the great thing that we just at least got out of the way for the time being, and they should investigate this for themselves and make a decision for themselves, is that there's a spot in this LCD that gives gratis for, we understand that you may still have a larger panel. We're only paying you for what's medically necessary.
Right, right. And I mean, at the strictest interpretation of this, what I'm also suggesting, though, is either you eat it, you redirect it, you get some kind of, you buy, grow, build another lab in one of these other states, you know, because it literally does say, you know, you need to be FDA approved or have a Z code. And, you know, unless you're, you know, using an FDA approved test, right? And even if you are using an FDA approved test, you still need to use these CPT codes and these diagnostic codes. Okay.
Gotcha.
But if you don't have FDA approval, my interpretation of which is fairly strict, I get it, is saying, even though it says these codes do not require a Z code, that's talking about something different. If you're FDA approved and you use these CPT codes and diagnostic codes, then you don't need a Z code. That is clear. That part is clear. But when you read this and you try to say, well, then I also don't need to be FDA approved, I think you're reading something else into that, right? Than what it really is saying. So, but hold on a second. Let's catch up with what's actually in the billing and coding article, because guess what is not in the billing and coding article? That means you don't have a diagnostic code and you don't have a CPT code to bill it. Well, what is not in here is UTI. So even if you don't believe me about the FDA and you're still going to try to move forward with either RPP or GI or encephalomeningitis or blood, or the UGAG panel, and I'll circle back on what that one is and how that one is not UTI, but just to prove to you that UTI is a thing, all right? So right here, that's the stuff we just got done talking about. They regurgitated the LCD when somebody asked, and this is the response to comments. And just so you all know how this works, because I actually had somebody that didn't quite catch this, is the comments are in the left side, the response is on the right side, right? Because somebody was reading comments and going, see, they said it was okay to do it. I'm like, yeah, no, that was what somebody else was saying, not Medicare, right?
That's right.
All right, so then here is the response. So the question was the requirement for registration of tests within the scope of this policy. So somebody was questioning, hey man, do I really have to be FDA approved to run this test, or do I really need a Z code? That was the question, right? And so they said, well, blah, 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 you need to be FDA approved or get a Z code, right? And then they give an example, right? So here's our example. As there are currently no FDA cleared or approved indicated uses for urinary tract infection panels, and there's no predicate, don't worry about what predicate means. It just means whether there's one there or not in the past that they could refer to, right? As such, at present, molecular UTI panel tests must submit for a Z code and undergo a technical assessment in order to demonstrate compliance with the coverage criteria of this policy. So even if you didn't believe me about the FDA thing, now you know you can't be billing a UTI anymore for two reasons. One, it's not FDA approved. Two, you don't have a CPT code. And three, you don't have a diagnostic code that they're going to know whether or not to pay for it or not, right? So
let me bring this back to patient care. All right.
Right.
So I've spent the last 4 years helping to recruit, hire, and train sales reps. And one of the markets that I love long-term care. And inside of long-term care, antibiotic stewardship and infection control is a big deal. And we've effectively have now long-term care facilities that have it baked into their protocol to order a UTI when a patient has a problem or frequent UTIs. They have pain. If they're nonverbal, if they're in an agitated state, whether that's bed sores for wound care, but for UTI specifically, there is a lot of magic that happens whenever we prescribe antibiotics appropriately to that patient population. Does the fact that they are inherently immunocompromised mean anything inside of this LCD?
Well,
for UTI?
The only thing that they even wrote down is in the LCD. There's nothing about it in the billing and coding article, so we can't bill it, right? That's clear without a Z code. But what you can see is they did write this. And so they did mention you need to either be, symptomatic and at higher risk for UTI, like the elderly. And then what is also interesting is that would preclude you from the requirement of having a urogynecology or urology specialty ordering it, right?
When we're writing this particular piece right here in the LCD, they are writing thinking that they're talking to somebody that has a Z code, had a TA, it's been approved. And when they get that approved, they get assigned, right, the Z code and the DX codes to use. Is that correct?
Well, yeah, part of your process for registering the Z code is you say these are the indicated, these are the reasons why we would run this test, and you pick from a list of indications, right? Diagnostic codes.
So if you're thinking about, oh shit, I got to get this done, in my mind, I'm going to help you say you need to have a physician or some type of a molecular pathologist, a clinical pathologist, or a doctor helping you, because they're going to be looking more into the clinical indications to approve this, right?
Yes.
They want to know that you're treating sick people. You're treating sick people. You're preventing hospitalizations and transfers, more expensive antibiotics, that you're smart, that you've put together a panel. Like if I'm thinking about culture and sensitivity, what happens in the Petri dish? All right, we have slow growers, we have no growers, but at the end of the day, I can identify those pathogens, right, with the Petri dish. Thank you, Dr. Koch. What I can't identify is the viruses and the fungus. So I'm expecting to see some innovation where we start fast tracking viral and fungal identification, and we leave the bacteria to grow inside of the Petri dish, unless they are notorious, like wound care, for being slow growers and growing outside of the host. But still, I can't bill for it without a Z code. I am a sales rep working for a laboratory that doesn't have a Z code for its UTI, and I have a long-term care book of business. How long will it be before my laboratory knows it's billing off the rails? I mean, will it just be a straight stop for UTI because it doesn't have the FDA caveat in it?
Well, okay, so some of what I'm about to say might be dangerous in the wrong hands, right? So unless they put edits in place, the CPT codes that people would likely use aren't even listed in the billing and coding article. Because there are no diagnostic code linkages to those CPT codes, I think it's potentially a very real possibility that we will experience Medicare's good faith payment protocols. And what I mean by that is, that's probably the most nicest way to call them of what kind of a payer they are. I think there is this misconception from any laboratory, or well, anybody that deals with Medicare really, is that, oh, well, Medicare paid me, so it must have been right, because, you know, I do get denials sometimes. So how can I get denials and then Medicare kind of turn around and say that they're not really checking my claim? Yeah. Well, it's, you know, without trying to teach billing, which would be really boring and dry to everybody, when there are certain things that will be very easy for them to catch. For example, if they had created an LCD and they did say that this CPT code needs that diagnostic code, well, that's pretty easy to build a database flag that a human never even has to look at and determine, oh, I'm not going to pay you that, right? But if you haven't set up those triggers in place, then things will sail right through. And then, of course, there are inherently things that have no spot on the claim. For example, a claim form has 33 fields. Well, there's, you know, there's A's and B's and C, D, E, F, G's, right? But there are 33 numbered fields, right, on a claim form. So there's a limit to what I can put on that claim. And a very real example of it in context of what we're talking about is there is no place on that claim where I put down that a test is FDA approved. So there's a couple of ways that this, if people just can ignore this LCD altogether, right? Two big things could happen. In the context of things that are in the LCD, they already said, look, we are not going to deny you because you don't have a Z code. We're going to assume that you are FDA approved when you use a CPT code and a diagnostic code in that billing and coding article. And if you are not FDA approved, they are not going to know that, and they are going to pay you. That's not a good thing. No, that's a horrible thing. Horrible. Because they will come and get that money back from you. Yes. And by the time they're doing that, they're going to be kind of pissed off too, yes, because they paid in good faith and they feel like they've now been taken advantage of, right? Because you didn't listen.
Well, if anybody, you know, we go back to dog years, right? And so this is the scary thing for me looking at the industry right now, is that we've got a bunch of COVID pop-up laboratories. We have a lot of techs and a lot of people that basically got into the business. They got a, you know, a quick quant up a 5. They went with some type of an out of the box test. They started slinging and ringing, and they started doing school testing, government testing, calling on urgent cares, setting up drive-throughs, and they harvested real cash. And then they thought, well, that was easy. Let's go ahead and validate UTI. Let's go ahead and validate respiratory. Let's validate wound care. Let's validate GI, because now it's just, this is my business and we have the money. But what they don't have is the experience to have gone through a ZPIC audit or go through a RAC audit. They don't know what it's like to have to produce medical records and physician's notes and the clinical laboratory developed testing accompanying documents to support that you were validated and your stability studies were on point, that you did all your testing within ranges, that you've got maintenance logs, temperature logs, QC logs, that everybody who worked for your laboratory was licensed and had the proper education and competency evaluation signed off on them. Like, if you haven't gone through that, you're in for a world of hurt whenever they ask you for their money back, because it's the United States Treasury that they turn it over to.
Yeah, you rob the people, right? And the people that go after you have their own agendas for what they're doing, but they also have the moral
authority.
Right. I mean, they are definitely cloaked, anointed to be feeling 100% justified and having no mercy upon your poor soul.
And if you
not knowing is not a good thing. Yeah.
If you need to go anywhere to look and see what they're focused on right now, when I say they, I mean the OIG. Go to the OIG government page and look at the hot sheets and see who they're investigating and what they're doing. And if you're doing what somebody was just found guilty or paid a fine for, stop, self-report, ask for help, like for real. But what William is explaining right now is that through no fault of your own, right? So maybe I'll take intent away, but they don't care. They still want their money back. That just means they're not going to prosecute you for fraud. Okay. So moral of the story here is there's no real clean way right now for a laboratory who doesn't have a Z code to actually bill UTI in particular effectively. Flat out.
Yep. I see no path to success here, but I'm actually concerned because, you know, there won't be linkages to some of the more common codes you would typically bill that with, that it might just slide right through.
So,
you know,
we'll see. We'll be asking questions on the 18th and 19th to laboratories that at least I consult with, talk to, and see, hey, what's actually happening? What are you seeing? I don't think anybody's going to test to try to break the law, but I think there are going to be people that I talk to that are going to be like, nothing changed, man.
Yeah, exactly. And you know, there's another thing too, like if there's no money left, I think that, you know, for somebody that has spent hundreds of thousands of dollars of the government money to indict somebody or get to go after a lab and there's no money, I think then you do kind of need to be a little bit afraid because they need something, right? It's blood or money, right? Yeah.
No, if they think that there's any kind of a construct to defraud them and make them it's a completely different. You talk to a different set of people. Hey, so tell me about toenail, and we spent time talking about UTI. I'd like to talk a little bit about respiratory and GI because those seem to be both capped at 5 pathogens as well. And then there's some specialty. They bring in the need for some specialists. And you know, I want to go back. There's a letter that was written by the American, I think, Molecular Society, Gastrointestinal Society, and CAP, and it's 2,500 physicians, and they summarized in July of last year a response to this LCD. And I'm tracking a couple of the blogs that I pay attention to, and what you referenced in the comment section is 25,000 words of comment.
Yeah.
Which has never happened ever in the history. I mean, like I've been in it for 11 years too, William, but I've seen people who have been in it for 40 years say they've never seen 25,000 words in a comment. So if you have a question, go to the comment section because there's a pretty good chance that somebody asked your question.
Oh yeah. Yeah, and by the way, about the nail thing, let's see, where is it? It's here somewhere. I thought this was interesting. I wouldn't even, where did it go? It's here somewhere. I just can't find it.
That's where it says the syndromic panels have been a challenge. These panels detect a fixed number of organisms, not all which are appropriate given the patient setting. During the season, some of these pathogens, in fact, extremely rare.
It's supposed to be here somewhere. I mean, it's like right here, but I can't see it. Do you see it? I'm looking for onychomycosis.
No.
It's got to be. Let's see if I say nail. But like they literally say in this LCD, huh, that's so weird. Like it's not working the right way. I need to update something maybe.
Oh, we'll get back to it. At the end of the day, what I remember hearing, oh, did I just see it? Nail? Multiple test culture organisms. No, it says multiplex NAT. So what I remember, just to kind of move it along, what I remember hearing from multiple sources is nails basically gone away. They're pretty much like, hey man, rub some dirt on it, like put some antifungal cream on it. It's okay.
Yeah, I mean, it says it down here in the bottom somewhere. It literally says the CAC. Oh, maybe that's what I could look for. The CAC is the community of the people that made up this LCD, and they're like, yeah, no, not nail, not for fungal stuff, right? Okay, so CAC, this is currently quite difficult. Let's see, where else did it say? No. While it's further to get base literature, feedback CAC's quite good. Listen.
Is it, well, like I said, I want to make sure.
Yeah, we don't want to take too long.
Yeah, but anyway, but this is really, these are the questions that you should be asking yourself. You know, if you've got a nail book of business and you're in one of these affected MACs, and it's easier for me to tell you what MACs aren't affected because it's just Novitas, NGS, and First Coast. And if you think about regions, that's basically Florida, Texas, New York. NGS kind of goes over a little bit to the other side, but that's basically the big state regions, right?
Yeah. Yeah.
So if you have a toenail book of business or a UTI book of business as a sales rep, and you're in California, you should be asking questions of your laboratory. What have they done to get Z codes? And if they have not done anything, you probably, and this is where I want to talk directly to the sales rep that's listening to this, dust off your resume, practice your interview techniques, and start looking at a way that you can get your patients to a laboratory that can run this testing. Because otherwise you're doing you and your family a disservice. The hard question here is, can I live a month without a paycheck? Could I live 2 months without a paycheck? Don't get blindsided on this one. Take control over it. Get ahead of it. All right. Ask your questions, and then you prepare yourself and figure out how you get out of this situation and work for another laboratory where your patients can get the care that they need and where molecular diagnostic testing is still paid for, right? Where it's not going to, William, do you see a flight of patient testing from the molecular GX, like the MolDX Max?
Yeah, I mean, it's either people are going to drop to doing, the microbiology, the cultures, right? Or those tests are going to have to go somewhere. Because I mean, if a lab is playing the game smart, right, they're going to not run the test, right? I mean, or maybe they're going to eat the test until they can get their Z code, right? And then they start talking about, well, can the Z code be retroactive, right? And as far as I know, the answer to that's no, you can't use a Z code. The date that it gets accepted into the DEX Exchange database is a recorded date. And if the data service is before the date that Z code was accepted, well, then you didn't have an active Z code then. And so you're not going to get paid for it. Maybe there's a way we could try to retro it, but yeah, I mean, this is what labs are thinking about is, well, can I still bill it the same way? And the answer to that's no. Can I retro it, not bill anything, and eat it for a couple of months until I get my Z code? The answer to that I think is probably no. I mean, I don't think they have this concept of like, credentialing, right? With Medicare, you could say, oh, I'm going to take and accept samples for up to a year, right? As long as I put in my application before I started taking my samples.
As long as your application was accepted by Medicare. I don't mean to use the words there because I've seen people who have sent in an application and they didn't fill it out correctly. They didn't have the necessary.
Then it's, you didn't get it accepted.
Clear. Yeah. And then they tested for 3 months, and then all of a sudden they checked the mail and they were like, oh no, yeah, you ate that expense, homie. Sorry.
Bad problem.
Yeah.
So any range of that stuff might possibly be possible with a Z code, but I wouldn't bank on it, right?
Right. Yeah.
So I mean, I think those guys should be pushing them to other labs that can still get paid for it, right?
Do you think you're gonna see is this the season where we see massive collaboration where laboratories, because you can't just reference. I mean, some people are going to go to, well, I'm just going to reference to another laboratory.
Well, you can't get paid. You could say, hey, take my samples and be out of it and no money, right? You could do that in the interest of patient care and not losing money by running the sample, right? But you don't really have a path to payment there, right? I'm sure some people are going to try to be smart or clever, this is a horrible idea. Do not. Actually, I don't even want to say it, man, but don't do that. Don't try to make a reference arrangement with another lab and extract money somehow. Mm-hmm. That is trying to circumnavigate it. That would be 100% wrong. But there's also nobody can tell you can't open up a lab in another state, right? Nobody can tell you can't do business, right?
So that would require, if you're a laboratory, you've got a book of business of a certain size, and we're talking about Medicare government payers here. Does this automatically going to roll down to like North Carolina Medicaid? Thinking about Palmetto, do they follow suit immediately, or is this changing this? I mean, like, is it just Medicare, or is this also going to be in those areas?
It's only payers that will have adopted the MolDX program, and there are a few commercial payers, right? So for a payer to try to emulate what this LCD is, they would, as a central component of it, they would have to be subscribed to the MolDX program. And there's a North Carolina Blue that is, I know that, and I think there's a few more, but no, so the Medicaids really can't do this.
Okay.
What they could do is they could say, well, you can only use certain codes, you have to have a certain provider order, you know, all that, but they really, they wouldn't be able to say you have to have a Z code because they wouldn't even know how to incorporate that, right? You
Understood. Okay.
Yeah.
All right. That makes fair enough. Fair enough. So
Yeah.
we're talking about, you know, on its face, we're talking about government, Medicare, Medicare Part B payer.
That's right. That's absolutely right. Now, and for the most part, as near as I can tell, for the commercial payer policies, they think of it as experimental investigational. So not really even a thing for them.
So we spent a lot of time talking about like what MolDX can be from a very restrictive, maybe surprise, threatening my livelihood, disbelief. Like you said it the other day on our phone call, like the 12 stages of grief, which I thought was perfect. And I've given you credit for it now twice. The next time. Hold the frame for a second. Like, how is this good for a laboratory that was paying attention, has their Z code applications in? They're like, we're moving forward. This is what we got to do. We knew this was coming. Like, could you have already applied for your Z codes?
Yes.
All right.
In fact, that's what the whole program has said. So this program has existed since 2011.
That's right.
And it is for molecular diagnostic tests. And yes, at the most part, it's been predominantly focused on the 81,000 series of codes, which include, you know, PGX codes, NGS codes, CGX codes. You know, it used to be more oriented on the, you know, $3,000, $2,000 per code type things, right? Where people were billing $10,000 panels, right? So that was the first thing they focused on. But they said very clearly, any molecular diagnostic test is going to be a candidate for adoption into the MolDX program. And so, you know, I can see how everybody's kind of surprised, right, about infectious disease, but they telegraphed this for quite some time. So yeah, you should be registering any of your molecular diagnostic tests with a Z code. You know, I mean,
and when you do, then you have a way forward and you know where you're getting paid.
Exactly. And I mean, like, for example, if someone were to say, recognize the benefits of having a lab in, say, Novitas and perhaps Palmetto or Noridian, right? There would be benefits, and there always will be benefits because of the differences in how payment gets done. But the way Novitas, for example, will deal with paying for pharmacogenomic testing, well, you're going to need four things, right? If you're in any of the MolDX MACs, one of those really big back-end problems of needing a diagnostic code, a specific one in relationship to a specific CPT code, disappears. So right now, what you will realize is during the ordering process in, say, a Novitas MAC, for somebody ordering PGX, they're not going to be able to go, okay, give me the med, then okay, now I have to figure out, okay, well, what gene does that go to, what CPT, okay, which group of diagnostic codes do I need to be looking at? Okay, group 2, okay, let me look through that now and see if my patient has one of those diagnostic codes, right? And if it isn't the right one, then you're not getting paid for that PGX test, right? So there's a lot of back end work that you've put on the ordering provider and or his or her staff, so that you can even have the information for you to even get paid for the PGX test you did. Well, people that have already got a Z code did all that work up front, right? So that's already been done. You don't need that really detailed set of data from the referring physician. So like I said, I think it might even be, not only was the playing field leveled, right? Because, you know, people were, you know, billing and making, you know, 2,000, in excess of 2,000 on PGX panels. You know, that's why you didn't see PGX testing in the other MACs, because, you know, you were going to get your 400 here or your 200 there or your 175 here, right? Okay. Well, now everybody's on that same level playing field. And in fact, I think it's a little bit easier if you already got your Z code done in those regions.
And so, I mean, so I think that's maybe the light at the end of the tunnel, and your HubSpot window's up, just so you know.
Oh,
I think that's maybe, and I see now onychomosis is actually there. Finally, there was consensus from the CAC participants that the use of this technology and the diagnosis of onychomyosis, fungal infections of nail was unnecessary.
Yeah. So, I mean, I wouldn't even bother trying to get a C code for nail then, right?
Right. Okay. So there's light at the end of the tunnel for folks that are about it. And that's the other thing too, is I don't want, a sales rep to think that their lab is guilty until being proven innocent. Like, there are some questions that you should ask them. The first big question in my mind is, hey, do you guys know what MolDX is? Because, we haven't been talking about it as a group. Number two is, do you know what test it actually affects? And see what they say. As sales reps, it's best for us to understand before we're understood. Going in there with a whole bunch of crazy, erratic anxiety is going to do you no benefit whatsoever. What you need to do is go and learn and assess the situation, because you literally could walk into a situation where they're like, yeah, we saw this coming a mile away. We have all of our Z codes ready. We're ready to rock and roll. In fact, look at the marketing material. We've been grooming you guys for this. We've been talking about this. We're prepared. In my reality, that's 1 out of 20. How many people have you talked to that this week, since this has kind of come out? You were early, April Fools. You did a webinar for Health Recon and did a really good job of explaining this. I heard people ask me questions about it from listening to what you guys have done. Lighthouse went yesterday. They got their opinion out, and they did a good job of painting why this could be a good thing for the industry. When you're talking to lab owners right now, what's your consensus? How many of them are prepared?
None of them. None of them are prepared. Yeah.
I wasn't expecting for you to say none. I was like, none.
Yeah, I mean, I had 5 people I talked to yesterday, and 3 of them were in the denial stage, and 2 of them were a little bit in the anger stage of, why didn't you tell me this sooner, right?
Yeah. I've seen people in that aspect. I didn't want to be little boy blue on this one, because I reached out to some folks that I trusted at first, and they tried to act like there's no big problem. And I kept getting that. And I was like, man, so I went and read it. And then I listened to you, and then I read it again. And then I listened to, there's a podcast on urology billing and coding that talks specifically about, it's in the App Store, and it's just for urology billing and coding. And they did an article or a 30-minute podcast on PCR and MolDX. And, they were talking about the range of the dollar amount that they should, people should expect. And it was way higher than I would have thought. They're also,
what were they saying?
They were thinking it's going to land around $500 or $600, but they were also saying that they had panels, and urologists had panels that were paying them around $1,100, which would be the highest UTI type of panel that I have seen.
Well, and if I may, then I'll show you why I would disagree heavily with that, and that's because the UGAG panel has got to be the closest thing to a UTI, but we know there is no UTI, right? Because they said there's no UTI, right?
Yeah.
So, and then when you look at what this UGAG panel is, these 2 are your women's health, your BVAP panels, right? Mm-hmm. Then this is still women's health. These are 3 HPVs, and they're worth like $30, $40, right? And you're only going to build 1 out of them at a time. Oh, by the way, this one was like maybe 150. This one's like 260, something like that, right? Now, the only 2 codes I have left where I would expect to see individual codes. There would have been codes here for each pathogen, and then there's a code that you use when you don't have a specific CPT code for a specific pathogen, but you get to bill it like 13 times, and all of them are worth $35 a pop. That's how you would find a panel or see a panel at a Medicare reimbursement rate of, as much as even 1,000, right? But if you're going to use an 87801, for example, which most people would have been, using an amplified probe, right? It's for multiple organisms, and this thing's worth $70, right? So this is what you are looking at in terms of coding. certainly a UGAG panel, which is for sexually transmitted diseases as well, right?
Mm-hmm.
Could have listed out gonorrhea, for example, and left you a code to bill for. It's not here. And it is not here because they don't want to pay for individual pathogens. You tell me how that's going to work out, man. I'm going to have my work cut out when I'm doing the Z codes. So when you do the Z codes, one of the steps is, hey, here's the CPT codes I want to use, right? And we're going to say, hey, we want all these individual pathogens. And I think they're going to go, yeah, I know that's what you want, but you're going to get this 87801. And then if we maybe fight with them, you know what else they've got an outlet that they can do? They can give us the unlisted code, the 87999. And that code would be the kiss of death in most scenarios because you don't have a fee schedule for it.
There it really? 87999 will also require a Z code.
Yeah, you need a Z code if you're going to use that, but also there's no, like, if you go look that up on the Medicare fee schedule, you won't find it. And you won't find it because there's no fee schedule attached to it, because what they're going to do is they're going to use that code for any test that doesn't have a CPT code that accurately describes the test. And then that you have to do a gap fill to try to figure out what they're going to pay you for that. You know, and at that point, you're going to argue, well, I did 10 pathogens. I want $35 a pathogen. I want $35. I want $350, right? And maybe they give it to you. I don't know, but it's certainly not going to be, sure, we'll pay you $800.
So
I mean, I don't think that's going to happen.
What I'm hearing you say, though, is that they've taken this literally now to a case by case, lab by lab, TA by TA assessment.
Yep.
And so like the better my TA is, the more proof I can show, the more convincing it is as far as like really understanding the problem. You hope that the person on the other end and the people on the other end that are reading and reviewing this, that they're bought into the argument.
And maybe they won't be. I mean, because there's, you could see in the LCD, they cited stuff about PCR testing. And one of the things that they actually said in there was, you know, for UTI testing, it's just too good. It picks up on stuff you don't necessarily need. We think culture is better. And I mean, that's going to be one of the hurdles about, I think, even getting a Z code for a UTI is you're going to have to say it's better than getting a UTI, right? I mean,
I'll give you guys advice right now. Take it for what it's worth. You got to focus on what is not there. You got to focus on what culture cannot do. You're not going to be able to win the argument. I mean, unless you are including a molecular pathologist, an anatomical or clinical pathologist, all that's reviewing and writing on your reports, that's calling the amplified copies pathogenic. Like, one of the problems that we have in PCR is that we have a report and it says low, medium, and high. And you have an antibiogram that's curating a database, and, you know, we're saying monolithically prescribe the right antibiotic. And so when you have something that's low, medium, or high, doctors are used to the MIC levels, and they want someone to tell them what to do next. And we bring in a decision-making process that they're not prepared for. So one of the reasons why doctors stop using PCR once they've started is because the reports are confusing and don't tell them what to do. And it's because the reports are coming directly off of the equipment without having a human being and an analyst call something pathogenic or not. So, I mean, I feel like I can't culture a virus under normal conditions. I mean, I can send it to a laboratory and have it specially done, but that's different. That's a biopsy, and its skin needs to be grown and all this other crap. Fungus, it's 6 weeks to never for it to actually grow. So if I want to figure out a deep fungal infection in 6 weeks, then yeah, good luck. But I got to do a punch biopsy, and I can put that in MTM and I can test it. If you focus on the viruses, I feel like this, if you focus on the viruses and the fungus, there's not a strong argument for culture being better than that. I mean, you know, so for clinic, and I am no damn doctor, but I have talked to thousands of them in the last 4 years about PCR testing. If there's two things that I know what doctors say no to for toxicology and for molecular infectious disease testing. I know the roadblocks and the objections, and I know what to say to paint the picture and convert the mindset. And if this is going to be an argument of converting the mindset of people about the differences between PCR and culture and sensitivity, sign me up. I know for a fact, my wife, we lost twin daughters because of an infection and the culture results coming in too late because the doctor was afraid to prescribe an antibiotic because she was in the 3rd trimester and didn't want to give her a blood clot. And the next day, she's literally in the hospital delivering the babies early. So, I've been an addict. I started selling toxicology and sold my story. I've lost children because of infection. I started selling PCR testing because of that event. It's to me, it sucks that this is what we're doing with a science that can save lives, that can help bring back the memory of patients in memory care units, that can prevent children from going to the emergency room, that has so much benefit. But because of bad actors that overutilize, and because of the money, we're now taking a step back and kicking innovation and throwing it out the window. Like that part sucks. But then you have the sales reps, William, like, what are you going to do? You got a book of business you've been building for the last 4 years with a laboratory that you love. And now all of a sudden they were asleep at the wheel like everybody else, and their revenue goes through the floor, and there you go.
Well, I mean, I not for me to destroy any lab's relationships with their sales reps, but you're going to find another lab, right? I mean, you just got the playbook of where to look for those labs, right? They're in Novitas, First Coast, and NGS, right?
Right.
And there's plenty of good people in those MACs, right? And they're already doing that kind of testing too, right? Mm-hmm. Or, there's going to be labs that don't have a book of business, that only knew how to do COVID and never actually knew how to interact with doctors to get samples. You might be able to scoop up a lab here pretty shortly for not much money.
I think the merger and acquisition play is definitely going to be something that people are going to explore. One of the things that's going to kind of get in the way of that is, just because I have you, I know we're talking about MolDX, and I don't want to go too far off, and then we're both got to wrap some stuff up in a little bit here. But talk a little bit about HRSA and the potential to bill HRSA when a patient really had insurance. Am I asking you a question that you're not prepared for?
No, but I'm. Let me make sure I understand what you're saying. Because you're not supposed to bill HRSA if people have insurance.
That's right.
All right. And so are you asking me how people made that mistake and did that?
Yes.
Okay. It's like, I thought you were trying to have me figure out, because there is this one slight caveat to somebody who had a certain kind of Medicaid that never had benefits for, like, the benefits for certain kinds of Medicaids are only for something, and it wouldn't have included diagnostic testing. In no such instances, even if you knew they had that kind of Medicaid, you could have billed it, because it's very clear. It's not about underinsured. It's about no insurance, right? It's not about underinsured. It's not about your insurance saying that you don't have coverage for it. You had insurance, you're uninsured, right? So that, just to make sure that we're talking about the same thing and not splitting hairs later about it, right? So how that can happen is, well, it's kind of based on the information you've got, right? So yes, Optum was doing something called insurance discovery, right? Which is a relatively newer service. A lot of people are kind of confused about what is insurance discovery and what is eligibility verification. And so here's the difference. Eligibility verification is, hi, my name is William Baus, and I have Blue Cross Blue Shield of Florida, and my member ID is MDX 5382. So you give me all of that information, I type it into a system, and I say, hey, Blue Cross Blue Shield, do you know William R. Baus with this member ID, right? And then they go, yeah, we do. And yeah, he was active on that date of service. So I've just verified the eligibility of William Baus. That's eligibility verification. Now, insurance discovery is, Well, William R. Baus lives at this address in Dallas, Texas, right? And that's all the information you have. And then you throw it at somebody, and then they go search through databases to look and see if they can identify a William R. Baus at that address with, having Blue Cross Blue Shield. So I can miss that. Like if you don't spell my name right, or you put my last name in first, or you don't put my middle name in, or you mistype my address, or you don't put my whole address in, or you don't do a whole bunch of other things, then it's going to sail right on by, and they're going to go, nope, couldn't find William Baus, right? Because you said Dallas, Texas, and he's not really in Dallas. He's in Carrollton, Texas. It's not fuzzy logic. So it would sail right on through. You'd get your temporary ID from Optum, and you'd bill it. Now, they're going to check that stuff again eventually. Maybe they can do a better check. Now, you'll notice also, this is too late to actually help anybody out, but if you were a smart biller, what you did is you split the uploads you were doing to get your temporary IDs in two. You did the ones where you had socials and driver's license numbers, because guess what happened? Came back like that, because guess what's in every insurance database, right? That information, and it could uniquely identify you, and it was a much quicker search. So they could send it through, get the response back, and tell you whether they did it. And they would even tell you, oh, these guys actually have Blue Cross Blue Shield. They would have told you what insurance they had. Now you uploaded stuff that was like this William Baus guy who was, I'm not giving you my driver's license, I'm not giving you the thing. Oh, and then I didn't give you my address either, right? So you were supposed to, in that instance, use the address of the location. How the hell was it? How were they ever going to come up with finding that guy's insurance, right? I mean, if you type in your name, how many of you are there? How many Blakes are there, right? I don't know. Burke might be a little bit, a Blake Burke, right? Be a little bit hard, but I mean, that's at least for me, right? In the whole country, right?
Well, so, the reason why I'm kind of asking it too is because what you just brought up and what you just explained, there's a material reason. And you know who is going to use eligibility or discovery? The auditors, when they come to audit you.
Oh yeah.
They're going to take a list of every single person that you billed, and then they're going to run a check and see if they actually had insurance. And if HRSA paid you and they actually had insurance, and guess what? Give us our money back. Now,
where's that attestation, by the way? You don't have your attestation? Ooh, well, now I'm thinking that's fraud, because I think you knew that they had insurance. Now you got to prove you didn't know they had insurance, right? Woo-hoo. And scary.
and then, yeah, you got to prove that you knew that they didn't have insurance, but you're like, well, then that's fine. I'll just go ahead and correct the claim form, and I'll just bill the appropriate insurance. You're probably past timely filing at this point in time. Reason why I bring this up is because for all you smart guys who are in a MolDX Mac and you think you're going to buy a COVID laboratory, please check the hair on the deal.
Oh yeah.
You very well could be buying somebody who has to pay. Their PTAN is going to be responsible for paying COVID money back. And so like, these are the things, the landmines that exist in the lab business, that if you're brand new to this, search for help. And when
you need a lawyer to do due diligence. You cannot do this on your own. And
you need a healthcare lawyer.
Yeah.
You need a lab lawyer.
A laboratory. I know a couple of very focused laboratory healthcare attorneys that do due diligence for buying labs. So
they're about to be busy. Yeah. They're about to be really busy. Well, William, look, as far as being able to find you or work with you, go ahead and give another shameless plug.
Sure. Right now, my personal email address is my name, williamrbaus@gmail.com. Email me and I will email you back. I will have a website. It's actually, it's there now. It's called Lab Revenue Navigator, but I don't have anything up. But by the time you see this, maybe it will be there.
So, well, you know, for me, one of the reasons why I appreciate you coming on here is because, you know, when we talk about frames and the way that we position people to be woken up, right? There are a lot of people right now who are asleep. They are asleep to this situation. And when you wake them up, you know, it's like if I was at your house, I went into your house in Carrollton and I opened the door without letting you know, and you're asleep on the couch, and you open your eyes and you see me standing over you, even if we know each other, You're going to go fight or flight. You're going to run away or you're going to fight me because I just woke you up. And now my presence is going to cause you to basically, there are a lot of people right now that are going through that. The 12 stages of grief, the reason why they're getting angry and they're in denial is because they were asleep to this and now they're threatened by it. Okay.
Yeah.
So you are in the process now of making them, they're going from asleep to awake to now aware. This podcast should have taken them through those 3 steps. So they were asleep to it. They woke up to it and they're like, wow, this is actually real. So now when you're awake and you're actually like, you had 2 cups of coffee. I knock on the door. You open the door. I try to sell you Jehovah's Witness. You're not scared of me, but you're not letting me inside your house. All right. So then now you go from awake to aware. Now I'll go to knock on the door, but you're already looking outside the window. You open the door before I get there and you're like, yeah, man, come inside. What we want now is for these ideas and these thoughts and these processes, we want the listeners and we want the decision makers to realize that this is something that you should bring inside of your brain. We're asking permission for you to consider these ideas for no other reason than but bettering your own situation, because there are going to be a lot of patient lives, provider practices, and sales reps, ultimately lab employees, that are going to hurt from it. Once they get through the aware stage, now they're alert. If they're smart, they're now going out and looking and talking and asking questions and hiring a consultant and filling out their Z codes because they're alert of the problem. And then they go through an acceleration phase where they are active and accelerating on solving the solution. They go to, I got to buy a lab. That's where they go to. I got to
also know there's that risk about that too, that, I mean, there could be some changes that will impact payment, but it's not going to be a Z code thing, right? I mean, they could do a couple of different things, right? I mean, they could create something like a MolDX code that would take years. They could make up a new LCD that's going to take months. They could do something like what they did earlier, where they just come out with a billing and coding article to clarify how things are supposed to be coded. Now that could happen relatively quickly. And if it was use 87801 or something, that would be just as devastating. So there's risk on all sides.
Yeah. And the they on that is actually Novitas First Coast NGS. Like they could modify, because right now they have a very broad definition, which opens them up to come and recoup a lot.
Yeah. And I mean, and they literally don't have anything that they're looking for a UT. It's as if they don't know what that is that they are paying for, right? If you build a wound panel, a UTI panel, the only way that they would know that that's not an RPP panel is because you didn't use one of those recipe codes, right? The 87631 or something, right? But the difference between a UTI panel and a wound panel, if they're not tracking what diagnostic codes they're expecting to see, right? They're blind to that. So what's happening is they're paying for that. They got no idea what they're paying for. They don't have a Z code. They don't have anything tracking what diagnostic codes. So they're going to stop that, right? They're going to do something to stop that. Now, whether that's make an LCD, to use the Lord of the Rings kind of, thing, one LCD to rule all the infectious disease panels, like what just happened here, right? Because everybody has 2 LCDs right now. There's one for RPP, which says we pay for 87631. And there's one for GI that actually says we'll pay for, 3 to 5, 6 to 11, or 12 or more. They'll pay for all of them. And all you need is acute diarrhea, 7 days or more, right? And you're done, right? And they don't say who has to order it or anything. Now, what they could do is they could make one LCD to rule it all, and then they could start putting those ordering provider requirements in place. But why would they do that? Because they already told us they're not paying for the 3.2 or the 3.3, which is the 6 or more pathogens. So they're not going to say it needs to be a pulmonologist, right? So I think they've already done what they're going to do for RPP. What they could do, though, is put out a billing and coding article, which would be a lot quicker to do. And they don't need this comment review period, right? Where, it's going to take 6-8 months to get done. And that's what worries me, because when you do that, right, and you say it's going to be 87801, well, now you all need to figure out how to do a panel and make it on $70, right? I don't even know if that could work, right? I mean,
So with that, if you want to stop the share, we'll go ahead and close the show.
Sure.
Yeah. So William Baus, one of the best names in billing and coding. You can reach out to him. He gave you his information. It's his name at gmail.com. I'm Blake Bork, host of Lab Results. Look, we're looking for results not only in your laboratory, but results in your life. And this one definitely impacts your pocketbook, your productivity, your lab's revenue. And then also because if you do it wrong, they're going to come back and ask you for money. This is the potential for you to bill incorrectly and be subject to a lot of recoupments. This is something to be taken serious. William and I covered a tremendous amount of ground, a lot of laboratory depth here as well. I appreciate you, William. I've tried to keep up with you, man. I hope I did a good job.
No, thanks, Blake. Really appreciate you having me on.
You got it. And we'll have you back soon because there's going to be things that are going to pop up, and I'm going to use you as a reservoir of knowledge if you're okay with it, my friend.
My pleasure. Yeah, we should do pharmacogenomics next time.
That's a good idea.
And I'm working on the No Surprise Billing Act because I think there's a lot of stuff we need to figure out for that.
All right, I got you on two of them. No Surprise and there's some. Anyway, those are fun to talk about.
Yeah.
All right, William, I appreciate you very much.
Awesome, man. Thank you.
You've been listening to Lab Results with Blake, and I'm your host, Blake Bork, with a closing message. Our whole target with this podcast is to positively impact the lives of 10,000 sales reps. And the best way we know how to do that is going to be by looking at the share button. The reason why is that's basically you telling us that we've done a good job impacting your life positively. And so you're now giving permission to share that message to your crew. So smash the share button. Let us know that we're doing a good job. Give us a like. That's great too. Subscribe. Absolutely. But the best thing that we can say is by sharing, greatness is contagious. And none of us woke up this morning to be average. We all woke up to be great. Thanks for listening. We'll see you again soon.